Am I on? All right, hello everybody. It's Part Soraya. Thank you for having me as we continue our perioperative conference that we're doing through Noon Conference this year. The first discussion we had was more about cardiovascular risk evaluation, and now we're going to talk a little bit more into the management of both the cardiovascular and a little bit of pulmonary management. The second lecture Dr. Eisen presented was on perioperative bridging, which was, I think, very helpful and good resources to have at that. So before I get started into the main topic today, I just wanted to kind of throw a little bit of a review slide into like what we've talked about so far. That way we can kind of get everybody on the same page, which is not working properly.
The PowerPoint might have.
Oh, it is stop. Okay, sorry. Let's see. I am going to, like, there should be a couple of things that pop up on this slide, but they're not doing it. All right, so can they still see this? Okay. Okay, so these are kind of the few things that I wanted to talk about before we move on to the topic. So some of the things I want to discuss were like, what were the three major indications of bridging? So starting with that question, if you guys can just send some comments in through the chat box, especially the PGY2s. I really want to gear this towards you guys that are going to PGY3. What were the things that Dr. Eisen talked about as far as why you would bridge in the perioperative setting? Okay, so we have a few responses that are back. The main things that we want to talk about are people that do have a mechanical valve. The biggest indicator is mechanical mitral valve. The aortic valve is also an indication, but the kind of studies have not been as clear-cut in terms of bridging. But for a mitral valve, 100% of the time you're going to bridge. With the aortic valve, you're also going to look at other risk factors to determine what to do. The other person that you might want to bridge is someone with a history of atrial fibrillation and a really high CHA2DS2-VASc score. So if someone's CHA2DS2-VASc score is greater than 5, like 6 or 7, those are usually the people that will bridge. And then the last but not least indication would be if someone has had a recent DVT or PE, which I think was mentioned as well, being an indication to bridge. So the big trial that gets thrown around is the bridge trial that kind of showed that bridging is not necessarily beneficial. It has more risks in the perioperative period, unless there are some acute indications like we talked about. So question number 2, what are some of the risk tools to identify patients at high cardiovascular risk? There were a couple of things that we talked about on the first day that you can use, so just kind of list out some of the names that you can think about. All right, so we need more participants. So please respond because it does help kind of get the topics moving. But The big risk tools, the one's already on the slide, is the RCRI risk calculator, and the other one is the NSQIP calculator. The RCRI is really the big one that gets pushed in most studies because it was validated externally at through multiple studies and multiple trials. And so the criteria that go into RCRI are also important that we should just kind of baseline be thinking about when we see a patient for the first time. That way we know what kind of risk they're going to be going through. So just list out, there's like I think 5 or 6 criteria. People can just list out some of those criteria that go into calculating their RCRI score. All right, thank you guys. That was great. So yeah, risk of the type of surgery that the person's going to get. So if it's intrathoracic or intra-abdominal, someone that's on insulin is at high risk. If someone has underlying renal insufficiency and their creatinine specifically that they highlight is greater than 2 is a risk factor. And then the other things that play a role is if they had underlying either vascular disease, whether it's coronary, whether it's a stroke or a TIA, that plays a role into the score. The last thing is a history of CHF. So if your score is greater than 3, that pretty much puts you at a very high risk, whereas a score of 2 is about moderate and 1 is low risk. So those people that are very low risk can usually move forward with surgery without having any acute, without having to worry too much about getting more testing done. The other thing we talked about was functional status, and so what makes a patient have poor functional status, and really the big thing, I'm not going to go into this because this can go into a lot of different answers, but the big thing that we want to talk about is the DASI score and looking at their metabolic equivalence. So if their med score is less than 4, that makes them poor functional status. And that usually you want to ask them questions like, are you able to climb up a flight of stairs? Are you able to pick up and do your own laundry? What kind of ADLs and IADLs can you do to take care of yourself? The last question on here is the risk tools to identify perioperative pulmonary risk, and I'm just going to answer this one too just so we can move on. But really the big thing is using that NSQIP calculator. You can use that, but you can also, they have derivatives known as the Gupta score and the AirSCAT score, which are both used to identify pulmonary risk. Okay, so today I'm going to go back into, if I can, the full sharing mode now. All right, so today we're going to talk more about the management of cardiovascular and pulmonary risk, the big thing is really how to get these people through the perioperative period and what to kind of help the surgeons in terms of how to properly manage them during and after surgery. So before getting started into it, though, I'm going to bring up this trial often today, but the VISION trial was done in 2012, and the reason that it was done was really to identify those patients who are at cardiovascular morbidity and mortality perioperatively. And so they took a look at the troponin levels, specifically the high sensitivity troponin level prior to surgery, and determined if it was elevated, which is greater than 0.2, that their risk of mortality was pretty high postoperatively. And so the idea is that if anyone has an elevated troponin, that's a biomarker for some type of underlying cardiovascular disease. And so Canada, I mentioned last time, has gone in and actually said that, if someone's going through an intermediate or high-risk surgery, you want to check their troponin preoperatively, and if it's high, then you want to, and their NT-proBNP, then you want to follow them outpatient for another 72 hours. This doesn't mean that they get like coronary catheterizations, but it just means that they are at risk, and maybe they need to be optimized more in the postoperative period. So I'll be referring to the study a little bit more during this presentation, but just to kind of get an idea of what it was about, that was the VISION trial. So here's the case that we're going to go off of today. So we have a 78-year-old female who's awaiting elective open reduction internal fixation of any kind of joint, has a past medical history of everything that you can possibly think about. So coronary disease, high blood pressure, hyperlipidemia, insulin-dependent diabetes, chronic kidney disease with a creatinine of 2.3, chronic AF, atrial fibrillation on Coumadin, her INR was 2.5, his COPD, and she uses oxygen at rest. She's gone through a CABG in the past. She's had a cholecystectomy done in the past as well. And those are her medications. So the big ones are aspirin, lisinopril, Lipitor, Coumadin, and beta blocker metoprolol succinate. Okay. So given that case, how would you guide this person's medication management? And you can just list out A, B, C, or D. Would you continue all three? Would you continue just the beta blocker and the statin, but then hold the aspirin? Would you hold all the medicines? And because her INR is high, you want to reverse it with vitamin K, or D. So just go ahead and say any one of those options. Okay, so for those of you that said B, that's correct. You do want to continue the beta blocker and the statin, holding the aspirin, kind of like we talked about at the beginning. This is someone that you may want to bridge, mainly because of their high CHA2DS2-VASc score. And the other medicines are safe to hold, but we'll talk about why and what kind of proof we have to hold those medications based on trials. So before that, which patient would benefit from blood pressure and diabetes, who's undergoing a hernia repair? You have a 62-year-old with a history of heart failure, renal insufficiency, diabetes on insulin, who's undergoing a skin biopsy. A 76-year-old with multiple vascular diseases who is scheduled to undergo a total hip arthroplasty tomorrow. Or a 60-year-old with high blood pressure, CHF, diabetes, with chest pain after climbing a flight of stairs, plan to undergo an elective laminectomy for spinal stenosis in 3 to 4 weeks. So again, the question is who gets started on the beta blocker. We're not continuing. We're initiating. Okay, so I should apologize. I just realized that people are trying to answer some of these privately, and and we're just sharing it with everyone. But yeah, for everyone that said D, that's correct. The idea is mainly that if you're going to start a beta blocker on someone, you want to make sure that you have enough time to see the effects of it, and not just acutely and rapidly start it, even if, especially if the surgery is like the following day. Because that can have some consequences both intraoperatively and postoperatively, which can result in hypotension. For some of the third years, I might have worked with Dr. Cook on during consults this year. There was a patient that got started on, I think, metoprolol, succinate, and they got like 6 doses because someone had commented on getting a beta blocker preoperatively, and the person became intraoperatively hypotensive and ended up in the ICU post-surgery. So just an example of why we don't do it in the acute setting, but for someone that has these risk factors that you think would benefit from a beta blocker, if there's time to allow for it to titrate, that's definitely an indication. So specifically, there's the European Society of Cardiology and the American Cardiology Association that kind of went out with the beta blocker initiation. So if someone's already on a beta blocker, you want to go ahead and continue it perioperatively. If someone has high cardiovascular risk and should be on a beta blocker but aren't, you can start it, assuming that you have time to titrate it is the big thing. So, the European Society says 2 days, whereas the ACC doesn't really comment, but says maybe about a week if you talk to a lot of cardiologists. The one thing I wanted to highlight that you might hear about in the perioperative literature is one of the trials was called the POISE trial, which was the first one that came out, and that trial actually showed harm with beta blocker during the perioperative period. But if you analyze the trial, they were giving really high doses of metoprolol succinate at about 200 plus per day, and they were initiating and they were developing complications intraoperatively, specifically with low blood pressures. But otherwise, definitely you want to go ahead and initiate if you have time to titrate. So then what about statin therapy? We said continue statin on that patient that we had. So the VISION trial, when they did a subgroup analysis on it, people were already continuing it to begin with before that trial came out, but this just proved that you want to go ahead and continue it because it does have decreased cardiovascular mortality and morbidity. The ACE inhibitors and ARBs, so you'll have a couple, I think, attendings that may want to try to say, you want to go ahead and continue that angiotensin converting enzyme during the perioperative period. And the reason that they're saying that is because when in the 2014 ACC/AHA guidelines, they said it's reasonable to continue during the perioperative period. You'll also have a lot of attendings that are going to tell you to stop it the day before the day of the surgery, and the reason for that was that same VISION trial that I talked to you guys about. The sub-analysis showed that there was a reduction in death and mortality and intraoperative hypertension by holding the ACE and the ARB. So I think, and probably as the new guidelines come out, I think more people are going to argue that you should be holding it the day of the surgery. So just kind of something that's another drug class. The big thing that came out in 2014 was the POISE-2 trial. So the same people that created that first POISE trial came out with a different trial. And what they looked for was the connection between aspirin and perioperative risk, specifically intraoperative bleeding. So what this trial did was actually looked at 2 drugs. One was aspirin, and the other one was clonidine, that they wanted to just see what the effects of those drugs would be in the intraoperative and postoperative period. So if you held it, what was the benefit? Well, if you continued it, what was the benefit? The big result at the end of all of that was the big risk with aspirin was intraoperative bleeding, and major bleeding postoperatively was higher for those that continued aspirin. So there might be keep in mind that this trial they excluded people that had a recent PCI. So if they have had a recent stent put in, we're not talking about that group of patients, but the ones that did not have any kind of recent intervention and they were on aspirin, they held the aspirin about 7 days before, and it didn't really affect the morbidity from a death standpoint, but from a bleeding standpoint, there was increased harm. So this just added to the common use of holding aspirin, generally about 5 days before surgery. The clonidine thing, I think they just wanted to throw another drug in there to kind of see what the effect was, and really just said that clonidine causes intraoperative hypertension. So I think they were kind of wanting to see if there was any anti-inflammatory benefit from clonidine, but there wasn't anything. But the big thing was the aspirin in this trial. So coronary revascularization, I've kind of highlighted what my standpoint is at the beginning of the first lecture, but what are the current guidelines for coronary revascularization? So if a patient has stable angina with two-vessel disease, they should undergo CABG prior to elective non-cardiac surgery. If they have stable angina with two-vessel disease, they should be initiated on guideline-directed medical therapy and proceed with surgery. If the patient has stable angina with two-vessel disease, they should be initiated on guideline-directed medical therapy, but the DAP should be held during surgery. If the patient has single-vessel disease, postpone the surgery until after stenting. All right, so it seems like B, C, and D are all kind of in favor. The idea behind this question was not necessarily what the cardiologist would do per se, but more kind of geared towards what the management would be from a perioperative standpoint. And the thought is that actual revascularization doesn't necessarily it's not going to change the outcome of the patient if the need for surgery is high enough. So I can see why some people thought that the elective surgery might be worth pushing back if it's elective and they can go through PCI. But really the question should be on, in the case of D, like what was the cause for the single vessel disease? Were they having a STEMI? Were they having an acute chest pain and unstable angina? And that might, that might go towards D. In this case, I put B as the answer, but the reason I did that was mainly because, again, the idea is that you can start someone on medical therapy and that acute intervention isn't necessarily going to do anything in terms of morbidity or mortality acutely. They're already at high risk, irregardless, and if that surgery is really necessary, in this case, the question should be how urgent or emergent is the surgery, and can we delay the vascularization till later? The reason why these things are out there and the questions out there, I mean, obviously we call cardiology if we were ever consulted on this in this kind of situation, but there were trials that were done. Main thing was the CARP trial, which was a coronary artery revascularization prophylaxis. So again, these are people that had that they went in and did a stress test or they did a cath and they saw that they had multiple vessel disease. Is it worth intervening on or is it worth not intervening on? And this is prior to surgery, and there was actual increase in death for people that underwent revascularization versus people that did not get revascularization. The other concept was that, what happened with with people that had post-operative troponin elevation. So same thing. You can start them on the optimal therapy, repeat potentially an echocardiogram after 4 to 6 weeks and see what the effect of the medical therapy is, because you might be able to avoid that acute revascularization and can do it at a later time. That would obviously change if they're having an acute STEMI in that situation, but just keep in mind that something that we kind of say is that the idea is that you don't want to necessarily be so aggressive and get everyone a stress test or get someone a catheterization unless there's an acute indication. Whether there's the poor functional status person that's going a high intraoperative risk, that one you might get the stress test on, but what are you going to do with the result of the stress test once you know that someone has disease? And then the question will go back towards the surgeon, well, how important is the surgery? And what are the risks or benefits from delaying surgery? So it's at the end of the day, it's a big discussion that needs to be had with all the consultants, including the cardiologist and the specialist. But just basically kind of considering all these things, we want to keep that in mind. The part of the question then becomes, what about people that have had coronary revascularization done in the past year or 2 years, and now they're on the dual antiplatelet therapy, whether it's aspirin and Brilinta or aspirin and Plavix? So what do we do with those patients? Oftentimes we have them on both. Do we just stop the aspirin? Do we continue the Plavix? Do we hold both? So I will leave you guys some time and maybe just respond with some answers, since I am going a little quickly here, but maybe just respond with some answers as far as what you think you would do with the aspirin and Plavix. All right. So the kind of idea behind this is, when exactly was that PCI done, and how long have they been on DAPT? So a lot of studies have shown that, especially with the bare metal stents, the risk of in-stent thrombosis is greatest within the 30 days after implantation. Whereas people that have had a drug-eluting stent put in, you're at risk of developing in-stent thrombosis for about a year. So for a long time, every single cardiologist and preoperative evaluation said, well, they've had this PCI done in the past year. They have a drug-eluting stent, so you should probably delay the selective surgery for a year. That kind of thought process has actually changed a lot, especially in the past 2 years. And because a lot of the newer drug-eluting stents that are out there, their trials are showing that it actually doesn't have as much of a risk of clot, and if the harm from surgery, delaying surgery, is more significant, then they should go through and proceed with surgery. So the ACC/AHA guidelines in 2014 highlighted that if it's been 6 months, you can potentially safely go through with surgery, but keep in mind that you want to try to continue the aspirin as a single agent therapy if you're able to, and that's a discussion to have with the surgeon. And same thing with the bare metal stent. Sometimes they'll proceed even if it's been less than 30 days, but I think more so with the drug-eluting stents that they're letting that happen. But if it's an urgent or a non-risky surgery, like say it's a cataract surgery or it's a skin biopsy, those patients you can potentially safely continue the aspirin without even having to worry just because their surgery itself is of low risk. So that's the big thing. So again, 2014 ACC/AHA, they recommended delaying, but that was updated in 2016, I believe, to saying 6 months to avoid in-stent thrombosis. They also said that the adverse events with are lower with drug-eluting stents, but then with bare metal stents at any time. So that's why that 30-day is important with the bare metal stent. And the last thing was the newer stents may require aspirin whenever possible in the perioperative period. The other thing that I wanted to mention going along with this, there are some patients that we have that that they do an angioplasty for and they don't necessarily put a stent in. So for that patient population, the current guideline is to at least give it 2 weeks before surgery is done, and again try to continue aspirin if possible. But if they just had like a balloon angioplasty done and no stent was put in, that's another population that we get asked about sometimes. I think this was pretty much highlighting the same thing. So again, the big thing is if it's a minimal bleeding risk surgery, like an arthroscopy, endoscopy, you can proceed without stopping DAP therapy. You can continue both. And like I mentioned, that there's been updates in the guidelines. Last, I wanted to complete the cardiovascular section of this topic with highlighting 2 trials that came out. I think these 2 trials are going to probably change guidelines a lot in the next coming years. That I think we're going to start seeing more and more being highlighted in both the ACC as well as European guidelines in terms of addressing it. So this trial was known as the COMPASS trial. What it did was they combined low dose rivaroxaban. This is not your standard dose, but 2.5 milligrams twice a day in aspirin in patients that have very high risk of vascular disease. It was a really high patient population, and that what they showed was that that it actually the benefit from having both those therapies compared to aspirin by itself was greater. So these were patients that had heart failure, diabetes, significant vascular disease, and renal insufficiency, and then they put them on rivaroxaban and aspirin, and they actually decreased the vascular events, and there was increase in bleeding, but it was non-significant compared to the high-risk bleeding that was out there. The other trial was in 2018. That was known as the MANAGE trial. This one used dabigatran, which is the direct thrombin inhibitor, along with aspirin to see what the effect would be in patients. This is specifically targeting myocardial injury after non-cardiac surgery. So this is the kind of people that you would deal with more so next year. And what this study showed was, again, that the combination of the 2 actually decreased vascular mortality and morbidity. And the safety outcome was not necessarily prevalent for when it comes to bleeding, whether it was life-threatening, major, or critical bleeding in that population. So again, I don't know where this is going to go, but it's just something that should be talked about and known about in terms of what people are testing out there and what the studies are out there for people with a significant history of vascular disease. So going into pulmonary risk a little bit, we talked last time about those 2 scores, the Gupta score as well as the AirScrat score. I think, hang on one second as I pull up. Again, I think I added these slides on later so they didn't come on the way I wanted them to. But the things to kind of keep in mind in terms of risk are there are patient-related risks, there's the procedure-related risk, and there's the risk scores that we talked about. So the patient-related risk, there's things that are related to lung disease itself, and there's things that are related not to lung disease. And so things like smoking, COPD, pulmonary hypertension, or recent infection are all lung-related. The ASA classification, the age, the kidney status, nutritional status, that's non-pulmonary related, but they're still important risk factors. And so those calculators will consider those things to determine if someone is at high risk of having postoperative or perioperative pulmonary morbidity and mortality. As I mentioned last time, the risk of pulmonary complications is greater than cardiovascular complications. People focus more on cardiovascular complications mainly because of the higher mortality associated with it. But in terms of actual prevalence, pulmonary risk is significantly higher. And so, kind of moving on, the tools that you guys should be able to at least mention in each preoperative evaluation. One is sleep apnea and who's at risk of having postoperative complications pulmonary-wise when it comes to their OSA. And so if someone is not on sleep, doesn't have a routine CPAP or BiPAP requirement, you want to consider their stop bang score and ask most and every patient, if you can, about what their risk might be for this disease. And what you would tell the surgeon postoperatively would be to maybe keep them on a sleep apnea monitored bed setting. The anesthesiologists are pretty good about asking these questions as well, but it's something that we should also include just to help our surgeons along, especially in the pre-op clinic. The ASA class, I just want to highlight this because we should know about it briefly. Big thing is if someone is the ASA class, I don't know why there's 2 on there 3 times. One should be a 3, and the other one should be a 4. But people with underlying lung, cardiovascular and pulmonary diseases and diabetes, but yet their capacity is low, they would end up being in the class 4 because they're at high risk of complications. Whereas if they're not, then they might be just class 3. So again, even though someone might be going through regular dialysis, if they're not having an acute episode or acute event from the dialysis, they go into the class 3 category, whereas someone that is in acute decompensation would go into the class 4. We rarely see people that are 6 because that's brain dead, and 5 is people that are severely warbound. They usually, if they need surgery, it's very emergent, and they, at that point shouldn't be necessarily even having us on board, but just kind of keep, something to keep in mind. The Malampati class is something that you hear a lot of in the step-down unit and our ICU unit, really just to kind of see how much of their soft palate you can see so that the anesthesiologist know how much of a risk of intubation there would be. So this is just a visual guide for everyone to use, but something to keep in mind is there's this thing called the upper lip bite test that came out in 2018, and it was shown to have increased sensitivity and specificity to see if someone has risk of poor intubation. And really the idea is to touch your lower teeth to the upper part of your lip, and everyone should be able to do that. If you can cross the vermilion border, that means that you're at low risk of having complications, but if you cannot cross it, that means you're at high risk of complications. It's the easy bedside test that everyone can use to determine and help the surgeons know, who might be at risk of difficult intubation. Last but not least, kind of things in terms of management itself. There's not a lot out there in terms of studies and trials. A lot of these are based on ACP. But the idea about chest x-ray and spirometry, so don't do routine chest x-rays, don't do routine spirometries. The real goal should be that if someone has acute processes going on, they're complaining of shortness of breath or dyspnea, and we don't know why, it's that patient population where you might want to target and get a chest x-ray or spirometry. But if someone is coming in and has a history of COPD or has a history of asthma, you don't want to just get routine chest x-rays or spirometries to evaluate their lung function. Smoking cessation is important for everyone. There used to be a time where people would just say, if the surgery is a month from now, then maybe consider stopping smoking. But just kind of given the idea that the actual morbidity associated with even post-operative smokers, now they just tell everyone, no matter how soon the surgery is, to consider stopping smoking. And then the other things are really guided towards people that have lung disease and lung history, so you want to let the anesthesiologist know that they're at risk of complications. So consider using like less anesthesia, consider using a neuroaxial anesthesia as opposed to general, and vice versa. You can say, postoperatively, if they're on, high risk of requiring CPAP or BiPAP, you can say maybe consider extubating to that modality in the postoperative setting. So the selective NG decompression is really a study that showed that people that have really high complication risks from nausea, vomiting, and ileus, those are people that require NG decompression, but it shouldn't be used towards everybody. It doesn't really benefit anyone, but the lung expansion modalities do benefit people, which is incentive spirometer that we kind of tell everyone to use in the postoperative period to avoid, avoid that first fever postoperatively from atelectasis and or pneumonia. So that's kind of the big guidelines for this topic. If you guys have any questions, you can ask them right now, or if you want, we can shoot me an email and I'll respond back to you individually. The kind of idea behind all of this is to make sure that when we're talking to our patients that we know, what to look for before even seeing them and while we're seeing them, but also how to guide our surgeons into medical management. And with that, I'm going to sign out. Tomorrow, I'm going to talk a little bit more about medication management that's beyond just the cardiovascular and pulmonary topics, and I will see you guys tomorrow.
Thank you.
No problem. I hope that was helpful.
Those questions are hard.